Right, and it is the end-systolic wall stress which determines the hypertrophy more than anything else.
Well, no, it's actually peak.
Yeah, the peak.
Yeah, but end-systolic is
I
not.
see what you're saying.
So I want to start with a story. Some of you guys who went out with us last night met my husband, who when you ask him if he's in the medical profession, he says, thank God, no. But when I started working on this presentation and was working with this image, he came up behind me and he said, oh, that's coarctation of the aorta. And I think the nice thing about MRI is that you don't have to point out all the details the way the echo needs to be pointed out with which vessel goes to which direction. The MRI really shows it very nicely, especially with the MRA, and you can see the exact anatomy, watch the vessels as where they go, and when you do the reconstruction, you can even see the trachea and the esophagus if needed. And so I think the nice thing about MRA is that it really brings together all the information, and you don't have to be really great at your imaging modality the way you do with the echo in order to get all the information. And it also can help you evaluate for hypertrophy of the ventricle, which I won't go into. I'll talk about that tomorrow when we talk about bicuspid aortic valves and aortic stenosis, but really stay with the MRAs or angiography so you can see the images. So here's another example of coarctation of the aorta with late diagnosis. You can see the tortuous vessels that come about that can cause rib notching on chest x-ray that we've learned, and the severity of the coarctation. Here's another example. And again, you can see how this one actually was a late diagnosis. This patient had an echo for hypertension approximately 3 years before the diagnosis of the coarctation. And the reason it wasn't picked up initially on echo is because you can see this is so far down from where the arch would be looked at by your suprasternal notch. And so they missed the gradient and they missed the coarctation completely. Here's a relatively young patient with actually a complete interrupted aortic arch. You can see this very thin fibrous tissue that's causing it, and actually the arch is completely being made by the patent ductus arteriosus that's connecting to the descending aorta. This is an interesting patient who actually not only has near interruption of the aorta, but also had a VSD. And so the images are not quite as beautiful because as you give the contrast, one of the things you do is you watch the contrast going through the heart before you begin the image modality. But as it's going through this heart, every time it gets to the left side, because of the coarctation, there's significantly more blood going across the VSD. And you can actually see the septum here as it's going around. I will show it again right here. And then the VSD at the top of the septum. This patient actually, after undergoing repair, the VSD started to get smaller since the pressure that it was working against wasn't as high. So this patient didn't need an intracardiac surgery, just had the arch repaired, and the VSD has actually started to get smaller on its own, or at least the shunt has gotten smaller. Here's a double aortic arch, and as Dr. Sanders showed you guys very nicely, let me try and play that again, sorry. The right arch is the bigger arch, as is normally seen. Here's a patient that had a coarctation of the aorta with a graft. Down here you see the graft in order to bypass the aorta. Here's a patient that had a coarctation of the aorta, and the reason I'm showing you this as a twist rather than showing you just the image is you can see how the subclavian artery fills later than the arch by retrograde filling because a left subclavian flap had been used. So you can see this doesn't actually come off the arch. Look up here. And it fills later when you're actually seeing the venous structure filling. Here's a patient that had a coarctation of the aorta that had what looked like an aneurysm at the graft anastomosis. We did a velocity-encoded image on them as well. And you can see here that there's actually no aneurysm, but just a little bit of a dilation that's occurring at the anastomosis. Here's a velocity-encoded image through that image, and you can see almost like a toilet bowl appearance to the blood flow that's occurring in that region. So turbulence flow that's happening there instead of the laminar flow, and you can see how by echo this would show up as one continuous jet, since we're not seeing the through plane color in echo images. So you can see how by coarctation of the aorta you can predict the gradient through the cardiac catheterization, representative here. And you can actually get very close to the peak-to-peak measurements that you would get by the cath lab. Here's what appears to be, by MRA, a widely patent anastomosis. Looks pretty good. The lumen size is not so bad. But then when we did the velocity-encoded image, we actually saw that there was a very specific spot right over here that had closed off and caused the anastomosis to not be as patent as it looks. And there's quite a bit of increased velocity across that region right there. As I said before, I'll talk more about bicuspid aortic valves tomorrow, but I wanted to show you how the bicuspid aortic valve region can definitely cause ascending root dilation. You can see quite dilation in this patient all the way up to the head vessels, and really resolution of that more towards the descending aorta. This is a patient that had a stent placement, and we wanted to look to see if there was any aneurysm at the initiation of the stent or at the distal end of the stent. And I wanted to show how, it's completely black because the stent is not there. And so you'd say, well, did the MRA, is that not a useful tool? But we can do other imaging modalities, such as something called HASTE imaging, where we can actually look very closely at that. And so here's the stent. And here's the area of the anastomosis of the stent. You can see it here, you can see it right there, and you can see it right there. And you can see that it's widely patent. You can see that the stent size as well as the descending aorta size is the same, that there's no aneurysm tissue around it, both at the initiation and the proximal end and the distal end of it. And so I think more than anything else, the cardiac MRI has helped in getting the images, the anatomy, and the flow data obtained by it. Provides a very sensitive and specific test for predicting gradients across approximately 20 millimeter gradients or higher can be predicted by cardiac MRI. The American College of Cardiology and American Heart Association in the United States have recommended practice guidelines that patients who have coarctation of the aorta receive at least a baseline cardiac MRI when they're old enough to not need anesthesia, and then at least one every 5 years to continue following, both for left ventricular hypertrophy and the patency of the aorta, both of the ascending and descending, even if they're asymptomatic. And so I think it's difficult to just evaluate them by echo, especially as they get older, and exercise stress tests may not give you all the information that you need. All right.
Thanks. Listen, we've gone 15 minutes over our expected time. So the deal is we'll do this democratically. You want to take an hour and a half for lunch, or will you take an hour and 15 minutes for lunch and come back at 14:30? Because otherwise you won't get out of here until 10 o'clock tonight. So I think that try and take a little bit less time for lunch, and we'll start at 14:30 promptly. Nice. You go ahead.
I'm going now.
You're going somewhere?
I'm going to Olympic field to meet my husband.
You're going to the Olympic?
Olympic Park to meet my husband for lunch and my daughter.
Okay, and when do you think you'll be
She's
back?
standing there waiting for me.
Your daughter's probably waiting badly for you, desperately. Yeah.
I'll be back at like 3. I'll be back at 3. Will you listen so you can listen? At 3:30. Norman? I'll be back. I can always do my hypoplastic left and my hypoplastic right second. Sorry, do you? Sir? Yes. So if it's a late diagnosis, we always do a brain MRI along with it to make sure that they don't have any bearing aneurysms. Yeah, I can let everybody know, but that's a great question. Yes, always do that. Anytime they're over 5 years old, when you diagnose a coarctation, I do a brain MRI with it. Makes it a long study.